Hello everyone, this is the second year Medico, and today we are going to see about bronchiectasis. Bronchiectasis is the irreversible, abnormal, dilation of the bronchi and bronchioles caused by the destruction of the muscle and elastic tissues of the bronchial wall. It may be a focal or diffuse process. It is classified into non-obstructive or pulmonary and obstructive bronchiectasis. Non-obstructive bronchiectasis. It is usually a diffuse type, presents as dilation throughout the lung. The cause may be post-infectious, genetic, immunodeficiency, autoimmune and immune-mediated diseases. Post-infectious cause, it may be the result or associated with chronic necrotizing infections. Bacteria such as Mycobacterium tuberculosis, Staphylococcus aureus, Haemophilus influenza, Pseudomonas. Viruses such as adenovirus, influenza virus, human immunodeficiency virus (HIV). Fungi such as Aspergillus species. Focal non-obstructive bronchiectasis usually develops as a complication of childhood infections, such as measles and pertussis. Genetic causes are cartigenous syndrome, which is an autosomal recessive syndrome with lack of ciliary functions, Young syndrome, dyskinetic ciliary syndromes. Immunodeficiency cause, patients with hypogammaglobulinemia, HIV infection, bronchiolitis obliterans after lung transplantation have increased susceptibility to infections, localized or diffuse bronchiectasis. Autoimmune and immune-mediated diseases. Autoimmune diseases, e.g. rheumatoid arthritis, Sjogren's syndrome, systemic lupus erythematosus, inflammatory bowel disease. Immune-mediated disease, example, allergic bronchopulmonary aspergillosis. Obstructive bronchiectasis. It is localized to the obstructed segment of the lung. Airway, bronchial obstruction. Partial or total obstruction of the bronchial lumen. It may be caused by tumor, foreign body aspiration and mucus plugs. It may also develop in patients with atopic asthma and chronic bronchitis. Cystic fibrosis. Major respiratory diseases in cystic fibrosis (CF) are sinusitis and bronchiectasis. Pathogenesis. It is complex process. Both obstruction and chronic persistent infection are the two major etiological conditions seem to be necessary for the development of bronchiectasis. Obstruction, it impairs clearing mechanisms of the lung, results in accumulation of secretions distal to the obstruction, leads to secondary infection, inflammation, weakens and dilates airway. Chronic persistent necrotizing infection, chronic infection in the bronchi or bronchioles, increased bronchial secretion, obstruction of airways by secretions, inflammation and fibrosis of the airway walls, weakening and dilatation of airways. Bronchiectasis associated with cystic fibrosis, it shows the importance of both infection and obstruction. In cystic fibrosis there is defect in the mucociliary action and there is accumulation of thick viscid secretions, leads to obstruction of the airways, favors microbial infections. With repeated infections the walls of airway are damaged and lead to dilatation of bronchi and bronchioles. In patients with asthma and cystic fibrosis hypersensitivity reaction to the fungus may cause allergic bronchopulmonary aspergillosis. This may predispose to proximal bronchiectasis. Morphology classification. According to the shape of the bronchial dilation, A. Cylindrical tubular bronchiectasis, it shows uniform and moderate dilation. B. Fusiform, characterized by fusiform dilatation. C. Saccular cystic bronchiectasis, it is characterized by markedly dilated bronchi which end blindly in dilated sacs. D. Varicose bronchiectasis, it shows irregular dilations and constrictions. They resemble varicose veins when seen by radiologic bronchography. According to the extent of involvement. 1. Generalized, it is usually bilateral and commonly affects the lower lobes. Left lobe is more commonly involved than the right. It is most severe in the more distal bronchi and bronchioles. 2. Localized, it is restricted to a single segment of the lung and usually occurs in association with obstruction, tumors or aspiration of foreign bodies. Bronchi and bronchioles are dilated and can be traced almost up to the pleural surfaces. Lumen becomes 4 times larger. Wall of the bronchioles are thickened by fibrosis. It occurs in the chronic cases, may result in partial or complete obliteration of bronchiolar lumens. Lumen is filled with thick mucopurulent secretions. Microscopy varies with the activity and chronicity of the disease. Bronchial wall. Dilatation of bronchi and bronchioles and destruction of their wall due to severe inflammation. If severe, may lead to lung abscess. Dense infiltration of chronic inflammatory cells, it mainly consists of lymphocytes and plasma cells within the walls of the bronchi and bronchioles. Sometimes, prominent lymphoid follicles may be seen. Fibrosis of the bronchial and bronchiolar wall, It occurs in the chronic cases, may result in partial or complete obliteration of bronchiolar lumens. Mucosal changes, desquamation of the lining epithelium and areas of ulceration is seen. Lining columnar cells may show pseudostratification and squamous metaplasia in the surrounding epithelium. Complications: lung abscess, pneumonia, empyema, septicemia, meningitis, metastatic abscesses e.g. brain, core pulmonal, generalized amyloidosis. Clinical course: severe persistent productive cough. It is the most common clinical feature. Sputum is foul-smelling, sometimes bloody. In severe cases, the patient present with dyspnea and orthopnea. Symptoms are precipitated by upper respiratory tract infections. Paroxysms of cough occur when the patient rises in the morning. This is because the changes in position lead to drainage of collections of pus and secretions into the bronchi. Thank you for watching.